Good afternoon, everyone. My PhD topic is about advanced strategies in improving outcomes during mechanical ventilation. I'm Csenge Szigetváry, currently working at the Department of Anesthesiology and Intensive Therapy, Semmelweis University. I've been working on 3 projects. The first is called individualized positive and expiratory pressure settings reduce the incidence of postoperative pulmonary complications. This topic is important because during general anesthesia, the ventilation and the mechanics of ventilation changes because of the mechanical ventilation, which will lead to an uneven ventilation of the lung and atelectasis in certain areas. We want to improve oxygenation and cause less harm to the lung tissue by optimizing the positive and expiratory pressure, the PEEP. And with our study, we wanted to know what is the optimal PEEP that is high enough not to develop atelectasis, but not too big enough to cause harm by overstretching the tissue. So we were investigating individualized PEEP titration methods. And our question was whether those patients who undergo abdominal surgery receive individualized PEEP, have less postoperative pulmonary complications and better oxygenation as those ones who are ventilated with the currently used method, which is the fixed PEEP settings. We found 17 eligible randomized controlled trials that investigated this topic, and now I would like to show you the most important findings of ours. The first is the PEEP that was used in these individualized methods. It was, on average, 6 centimeters of water higher pressure than the currently used fixed PEEP settings, which is important because the currently used setting is around 5 or 6 centimeters of water. And that means by this individualized PEEP, we doubled the required pressure. Regarding our other primary outcome, the postoperative pulmonary complications, with an odds ratio of 0.52, we could see a significant reduction in those patients' pulmonary complications after surgery who were ventilated with this individualized PEEP. Another important outcome that we investigated was the PF ratio, which is the pressure of arterial oxygen over the fraction of inspired oxygen. And this leads to a ratio which is normal between 300 and 500. And the higher this ratio is, the better oxygenation the patient has. And this ratio seems to be, on average, over 50 milligrams of mercury higher in the individually titrated PEEP group, which is not only significant mathematically, but this number is a very relevant clinical improvement too. As a conclusion of our study, we can say that these individualized PEEP settings were nearly 6 centimeters of water higher. It reduced the incidence of postoperative pulmonary complications, and it led to better early postoperative oxygenation. I would also like to mention that some other data we examined showed a better lung mechanics in this group, but we could detect a higher chance of developing hemodynamic instability in these patients. As a summary, what is the strength of our study is that we only included randomized controlled trials, and to our knowledge, to date, this is the first meta-analysis on this topic examining patients undergoing abdominal surgery. The limitation of our study is the heterogeneity of both the population we investigated, both the titration methods and the measurement of the outcomes and time points. What is the implication for further research is to do and repeat these investigations on a more homogeneous population regarding the patients and the surgery, and to have some consensus on how to titrate PEEP, because there were several methods. The implication for practice is improving the oxygenation status of this patient and reducing their postoperative pulmonary complication chance by using these personalized methods. Currently, the manuscript is ready, and it's going to be pre-submitted to anesthesiology. Our second project is going to be an initiation of a registry on acute hypoxaemic respiratory failure. This condition is the leading cause of need of admission to the ICUs, and it is associated with a very high rate of mortality. And currently, there are neither registries in critical care in general, nor on this topic in the whole Eastern Europe. So we would like to collect high-quality data, both on standards of care, procedures, and outcomes, to also improve the treatment of Hungarian patients. We have our registry resources. We have we have developed our inclusion and exclusion criteria, and our questionnaire is almost ready, and we need some ethical approvals. The third project I worked on is called hemoadsorption as adjuvant therapy in acute respiratory distress syndrome, ARDS for short. This is usually a secondary result of a dysregulated inflammatory host response. Hence, immunomodulation by removing cytokines extracorporally may improve the recovery of these patients in the early phase of the disease. So our PICO is whether those ARDS patients who receive, we want to check if the before, what's the difference between certain outcomes before and after this treatment of patients with ARDS who received hemoadsorption therapy. We conducted our systematic search and selection, and we found about 20 eligible articles. And I would like to show a few really fresh data. First, I would like to show this inflammatory marker, the IL-6, the serum level before the treatment. And after the treatment, we can see a significant reduction, probably caused by this therapy. Also, we can see a significant improvement from the before and after phase of the previously mentioned PF ratio among these patients. These are individual data pulled from case reports. And we have some case series on this topic. Also, I would like to show the PF ratio, and you can see a significant improvement, significant overall improvement of these patients after the treatment. So these were the 3 topics I've been worked on during these 15 months. I thank you for your attention.
I really hope if ever I have a surgery, my anesthetist will use individualized PEEP. But my question is, you wrote, there is a, maybe I misunderstood, but you wrote something, the recommended Hungarian centimeter is a 6.
Yes.
What's the?
This is what
it's 6 millimeter higher. So in the case that it's not individualized, that means that you recommend the generally used.
Yes. There is a recommendation of a so-called I cannot recall it in English, lung protective ventilation. And there are some recommendations on what a lung protective ventilation is. And one point of that is somewhere written, is that we should use PEEP. And it's recommended around 5 or 6 centimeters of water, to my knowledge, currently.
So is it possible to use this as a new recommendation, or not because it could be danger when it's not individualized?
I think, another important thing here is that in this study, it was an exclusion. So all the study that was included included patients without any pulmonary dysfunctions or disease. So when there would be an overall recommendation, we have to consider those patients too who may have some lung diseases such as an emphysema or something. These are like healthy lungs. But yeah, I think it's a very profound and surprising data that maybe we can be more brave to elevate the PEEP, maybe.
Technically, I was thinking about that you wrote that there are many types of calculating this PEEP, am I right?
Yes.
Is there a significant difference between the calculations? So we should choose technically a complicated kind of calculation for a better result? Or it's simply, if we use the simplest way, would be enough?
Mm-hmm. That's a really, really good question. Basically, all the methods they used aren't really complicated, aren't really more time using than the others, and aren't really costing much. These are relatively costless methods. For example, I would like to mention is that we can see a few really elevated ratios here. And these are same methods. So there was a method which at this outcome seemed to be the best, but maybe it's just an incident. So I don't know if that was your question, more like the which one to choose or which one is better.
Yes, technically, yes.
Yeah, okay.
Thank you.
Thank you.